I'm sorry? Recorded? Not yet. I will post it to you. I mean, I will send it to you guys. So guys, this is a rat question that I had, rat exam that I had from last year. So let's just look at the questions, see if you can answer them from these are the anti-diabetic drugs, okay? So the first one says, which glucose transporter is insulin dependent? We all agree it's C, right? Because why is it C? Why is it the GLUT4? What does it mean to be insulin dependent? So it's not going to be able to transport the glucose before insulin binds and stimulates the release of these transporters, okay? Now, GLUT2, on the other hand, it's not insulin dependent. It's there at the pancreatic cells all the time, at the cell membrane all the time, and they let the glucose in regardless, okay? Okay, the next one, increasing solubility of insulin gives it longer duration of action. False, we all know it's false. And then the C-peptide chain of proinsulin connects polypeptide chains A and B of the insulin. True. We all know it's true. I'm sorry? Why is it false? Yeah, it's proinsulin has chain A, B, and C, right? Yeah, so it's true. The way it is worded, I can see proinsulin has chain Oh, okay. I can see that. Yeah. Okay, but you get my point, right? I get your point. Okay. Yeah, I know. So I know sometimes I mess up with the wording of the sentence. But if this ever happened, let me know. Like, in the exam. Okay, guys, this is important. Shh. If you see something like this where the wording is like confusing, it could be interpreted in many ways. Let me know. Okay. All right. During the exam? Not during the exam. After. Okay. Yeah. In the exam, I'm not allowed to answer any question, and it's just on your own. You can leave a note. For me after the exam, I can read, or you can talk to me after the exam. Okay. Yeah. Number 3 is true. Yes. Yeah. Okay. Biologically active form of insulin is hexamer. No, it's false. Which one is the active form? Monomers. What about dimers? Nope. Good job. See, now you wish you have taken the rat, didn't you? No? Oh, after I taught it. Okay, I see. Good. That makes me feel better, even though I messed up a lot today. Yes, I'll send everything you'll see here, I'll send it to you. I'll share it with you, everything, okay? Okay, adding more zinc ions to insulin gives it longer duration of action. True. So we have an example of 2 zinc, and we have example of 4, and then the 4 has ultra long duration of action. Okay. This one I did not teach or did not stress on much. So, oh, you know the answer? B, is it? Yeah, it's B, lysine. So, okay, well, all of them are red. I was red in my diagram. Okay, yes, it was, yes. Yeah, you're right. Okay, so guys, remember the exenatide or Byeda? It's another form of the GLP-1, okay? So, but GLP-1 has problems with stability. So in order to improve the stability, they found that substituting this amino acid lysine would enhance the stability, okay? And that's what happened. That's why Byeda is more stable. Okay. What about this? Insulin binds to receptors alpha subunit, which are located inside the cell. Why is it false? Located outside. So which subunit located inside? beta. Okay. Next one, what structural feature is responsible for enhancing the activity of the second generation sulfonylurea, A, B, or C? A, part A. We all know it's part A. In fact, if you compare this second generation with the first generation, you will see that the difference is in this part here, okay? So in this case, first generation versus second generation, what was the problem with the first generation? Huh? Okay, so potency was a problem because you need to give higher dose. So now you, with the newer generation, you give less dose, but there's something else too. Say it again. They causes toxicity. Why? They stay longer in the body. They have long duration of action, right? So they have longer duration of action than we need. So guess what? We're modifying the drug to give something that has reasonable duration of action. So you will see that, you know, throughout the remaining lectures that many times you modify a drug to increase duration of action or reduce it. It depends really what you need, okay? And as you know, you need the drug to stay there just long enough, reduce the effect, and leave the body. We don't want the drug to stay forever and cause toxicity, okay? Okay, and then insulin is stored in the granules of beta cells in the form of dimers. How is it stored? Hexamers. See, I always highlight, you know, the part you need to focus on. So you're not looking at, is it stored in granules, in beta cells, okay? You know, just so you don't overthink about the question. And then number 10, glucose is freely absorbed by the cells. False. We know that they actively absorb, they need energy. They need transporters to be absorbed to the cells. Okay, so let's look together at the applications for that part. Okay, so this application, compare between the two main types of glucose transporters, identify which one is the most abundant, and also the only one that's identified up to date. Okay, so we already talked about that. There are two kinds, right? GLUT and SGLT. And the most common one used in the transport of glucose inside our cells are GLUT4, which is insulin dependent, okay? And then in the next application, talks about describe the insulin stimulated signaling pathway that lead to the transport of glucose inside the cell. Which pathway is this? The one that involves GLUT4 or GLUT2? Insulin stimulated, it depends on the insulin, and it leads to the transport of the glucose inside the cell, so that's GLUT4, okay? And then talk about the structure of the insulin and the importance of the C peptide. We already talked about that. So we have pro-insulin, and then pro-insulin, and then insulin. So which one has all the peptides A, B, and C? Pro-insulin. Okay, and what is the importance of the peptide chain C? Two things. Shape. What do you mean by shape? It helps the insulin to fold in the correct conformation, the active conformation. If it was not for peptide C, the insulin will fold, or the proinsulin will fold in a different way. I mean, I'm sorry, it would be an insulin then. It would fold in a different way and it would be inactive, okay? And the second reason, why did we have, why did we not like synthesize insulin when we did the recombinant DNA technology? Why not synthesize insulin instead of the proinsulin? Okay, I mean, I think what we're trying to say is if we don't have the C, we won't be able to make A and B because C connects part A and B. So we cannot tell the bacteria, okay, synthesize this part, then stop and synthesize the other part and then make the sulfide bond. No, we cannot do that. But we can tell the bacteria to synthesize this whole chain, okay? And of course, the sulfide bonds will form by themselves, the protein will fold, the insulin will fold in the right way, and then we can cut the part C, okay? So helps with folding in the right way, and it's difficult to, make only A and B without C, because C connects these two together. Any questions about this? Identify the techniques used in designing insulin analogs with longer duration of action. Can you talk about the techniques again? First of all, let's talk about designing the short duration of action, or let's say the immediate insulin. How did we make that? Changing terminal amino acids. What happens when you do that? It becomes faster. Why is that? It's a monomer. It can, yes, because apparently these newly amino acids added, they prevent the formation of a dimer. So when you use this new form of insulin, it will stay as a monomer. When you inject it, it's readily a monomer. It's not going to form dimers. It will dissolve faster. It will give immediate effect. Okay. Okay. Sure. So when you have, the technique that we use to make the insulin dissolve faster and have immediate effect is by modifying terminal amino acids, 2 terminal amino acids, and replace them by other 2 amino acids. The result is this new insulin cannot form dimer. It will stay as a monomer. Basically, it cannot bind with another insulin, okay? And it will stay in the monomer form. So when you inject it, it will stay in the monomer form. It's readily soluble and able to give you the effect, insulin effect, okay? Now you can think of the same technique, but using different amino acids to enhance the formation of the dimer, right? Right, so, or maybe enhance the formation of hexamer, only by modifying the amino acids. This way, you are encouraging the formation of dimers or hexamers, and then the drug will be less soluble. This is one technique. What other techniques have we used to increase the duration of action? Say again. Okay, so modifying the amino acids such that at the pH of 7.4 or pH of 7, roughly, we have a total charge of 0. Okay, so isoelectric. When we have a total charge of 0, it's like the same concept when we had of ionized and unionized, right? So you have ionized will dissolve, unionized will not. So when you have total charge of 0, the insulin will be less soluble. Okay, so modifying the amino acids to make the total charge at pH of 7 or 7.4 to be 0, so it's isoelectric. Okay. So what about the pH 4 in the reading? It talks about pH 4. How is this related to that? To make it and put it in vials, okay, it has to be soluble. You cannot sell it in crystal form, right? So you dissolve it at pH 4, because at pH 4 it's not 0 electric point. It's not it does not have a net charge of 0. Just like when we had the pKa and pH of some drugs, ionized, unionized, by changing the pH, you could make the drug ionized or unionized and then affect the solubility. The same way here, we have at pH 4, this drug that we made is now soluble, so it's ionized. So this is another technique. And table number 10 mentioned, I'm sorry, I forgot her name. But she talked about adding a zinc, right? So you could add 2 zinc ions, which would bind to the insulin, which is negatively charged, and then makes it less soluble. Or you could add 4 zinc ions and bind to the insulin, makes it, again, even more, I guess, even lesser. No, there's no such word. Even less and less soluble, okay? So zinc, positive charge, bind to the insulin, prevents its solubility. There's another technique that's similar to the zinc. We use something positively charged. What is it? Protamine. In fact, if you look at the, in the pharmacy you work at, look for insulin that has NPH, okay? So the N stands for protamine. So protamine is positively charged. Again, it binds with the insulin, which is negatively charged. It forms complex. It delays its solubility, and then again, extended duration of action. I think there is one technique left. What is it? Fatty acids. So we could use 14 or 16, I think 16, 14 or 16 amino fatty acid chain to make it lipophilic, and this way the drug would stay even longer. Okay. Now there is something about how the insulin looks like. So which one do you think will look cloudy? Which one will look clear? Let's talk about short-acting, immediate-acting insulin and long-acting insulin. Which one will look cloudy? Which one will look clear? The solution itself. The long-acting will look cloudy. The short-acting will look clear. Right? Why is that? Solubility. So the short-acting, they will look clear. They are soluble, which will help patient differentiate between the long-acting and the short-acting. And I'll give you an exception. But first, let's get this clear. By having clear solution, it's a short-acting. If it's cloudy, then it's not soluble. It's the long-acting form, which makes sense, right? Because the insoluble form will stay longer in the body. Now, there is one exception of a long-acting that is actually cloudy. I'm sorry, it's a long-acting, it's clear. This one here is an exception. This one here, the glargine, is a long-acting, so it's supposed to be cloudy, but it's actually clear, okay? Okay? So normally people or patients would rely on how the solution look like to differentiate between the long-acting and short-acting. Of course, they should check the name, but sometimes they rely on that. If they do, then if you use something like glargine, then you want to make sure that it's not cloudy, it's clear, okay? Why is it the case? Let me look at the mechanism itself. So glargine, let's see. So actually, this is the one where we had to make the solution, I mean, the insulin isoelectric, but then which pH did we dissolve it at? pH 4. So it's actually soluble in pH 4, and it looks clear. Well, yeah, I mean, the other ones are short acting. Let's see. So the clear ones are the rapid acting, okay? Up to here, the short acting and rapid acting are clear, okay? These are cloudy. So these are intermediate acting and long acting, they're cloudy. I mean, in theory, they should be clear because they should be soluble, right? I mean, you can argue about that because, you know, that's why we made glargine in the pH 4 to be soluble. But I guess the cloudy one is not crystallized. It's more like, you know, suspension, okay? You know, just like the antibiotic suspension, you dissolve them. Excuse me. Okay. Okay. This talks about okay. Here we're going to compare the different mechanism of action for the oral hypoglycemic. So we have the secretagogues ones, like the sulfonylurea and the metiglitizides. These bind to the sulfonylurea binding sites at the potassium channel. They block the channel and therefore enhance the secretion of insulin. We have the insulin sensitizers, okay? These are like metformin and the PAR, was it PAR 4 agonist? PPAR agonist, yeah. So PPAR agonists, these were insulin sensitizers. And then we have the alpha glucosidase inhibitors that inhibit the breakdown of the sugar in the stomach. Okay, they prevent their absorption, but problem with this is that they cause, you know, gases and diarrhea and all these nasty things. The good thing is they, you know, with time, your body get tolerated, so you should take them gradually. So start with a slow dose and then gradually increase the dose to avoid these side effects. And then of course, the last one, which I got lost about, the MLN agonists. I have to explain that at some point. But then you have GLP agonist and DDP4 inhibitors. So this figure here shows the incretins, which stimulate insulin release and inhibit glucagon release, which is good because it reduces the glucose. Then our goal is either to synthesize something similar to the GLP-1, like the Byeda and Victoza, or to inhibit the enzymes that break down these, okay? So we have an enzyme called DPP4 that inactivates these, so we inhibit that, okay? So this is the general mechanisms of the hypoglycemic agents. Any questions about this so far? And then I believe this was the last exercise, yeah? Explain the rationale for using designing analogs that are more stable. Okay, so we, in this case, to make them more stable, we replaced one of the amino acids. It was the lysine, remember in the rat question? So we replaced the lysine with a different amino acid just to make the drug more stable. Okay. So hopefully these exercises, you know, help you understand things better, maybe. Yes. Yes, I will, yeah. Yes, so I will post everything on Canvas, and I will also send it to you by email. Any questions? I'll give you a minute to think about any questions on the anti-diabetes. Yeah. Yes, so let me show you. So that's the one I'm talking about. So this position here, this amino acid was replaced by another one, which turns out to stabilize the peptide chain, this protein, so it's more stable, it stays longer in the body. Okay. What about Victoza? What did we do with Victoza to increase its duration of action? Yeah, Victoza, we added a fatty chain to make it more lipophilic and would increase its duration of action. So it's less soluble when you inject it. All these are injected subcutaneously, guys, okay? Just like insulin, it's given under the skin. So when you inject it, it does not dissolve as fast. They're lipophilic, they stay longer, okay? So you will see that Bayeda is given twice a day, Victoza is given only once a day. Other questions? Excellent. Yeah. Okay. Yes. So her question is, how do you choose, which is the best medication to give? This would be clinician job. Okay. So you will learn about this from the clinical faculty. You will see people specialized in internal medicine, people specialized in infectious diseases, people specialized in psychiatric diseases. These are pharmacists that will come and teach you about each topic, about the clinical aspect, okay? What is the best option? We have, type 1, type 2, all these, you'll see it in a protocol. We have certain steps you follow to find the best option, okay? Good. Okay, let me go through the exercises I had for the osteoporosis. Again, this is for your own education, but I know you guys like to learn, so, or don't you? Okay. Okay, so the bisphosphonates, which sentence is most correct? They have good oral bioavailability? No, they don't. That's why we take them on empty stomach and we try to avoid taking them with any food or calcium because they could, prevent their absorption. They are mainly excreted by the kidney. I think that's true. I think they are mainly excreted by the kidney. They interact with many cytochrome B450 enzymes. Do they interact with many? No, I don't think so. I don't think they are metabolized. They are not even metabolized, right? These are the, bisphosphonate. Think of them as, negatively charged molecules that are excreted in the kidney. They don't even go through the liver, okay? And why is this important? Why do we care about how the drug, whether the drug is metabolized or not? Where is it excreted? Exactly, because you might have a patient who has a liver failure or kidney failure, then you want to look how the drug is metabolized or excreted, okay? So in this case, if somebody has a liver failure, would that be a problem? Liver failure? No, because the drug is not even metabolized. But if the patient has a kidney failure, then that would be a problem, and then you want to consider those adjustments, okay? Okay, and then option D, should be co-administered with calcium. I would not see co-administered. I mean, you will see actinyl calcium, but like we saw in the pack, they are actually given at a different time, okay? They cannot be co-administered with calcium or antacids or anything that has positive charge. Okay, using the attached figure of the pre-parathyroid hormone, which is the part that's shown in red? I think it's C. So we have, pre-parathyroid and we have parathyroid and we have parathyroid. And then this part in red is the only active form. So since the others, are useless, so we synthesized a drug that is only the active form in red here, which is the teriparatide, okay? So this form in red is actually the C. Okay, now which one of these is the active form? These are vitamin D, right? The one with the 3 OHs, excellent, thank you. Because if you think about it, it's, the first step you add OH, the second step you add another OH, so now we have 3 OHs, which is the vitamin D, okay? So we have D3, we have the calcifediol, 25, which is 25 hydroxy vitamin D, and then we have 125 dihydroxy vitamin D, which is actually the active form. These are inactive, okay? Okay, what's the purpose of replacing the oxygen here with a carbon? Exactly, not hydrolyzable, meaning like more stable. Thank you. And it has nothing to do with the binding affinity or the potency. In fact, B and C are the same. If you enhance the binding affinity, then you also improve potency, right? Remember? And I think that's the last one, no. Okay, so this one here will not cover, but it talks about the denosumab mimics the biochemical effect of which one of these? Oh, you know the answer? You're good. Okay, so it's rank, is it rank L? Okay, let's look at here. Oh, the osteo, okay. Good. It's inhibitory and it mimics this one, so it inhibits this. Okay, yeah. Now I'm thinking I should put the material back on the exam. No, not at all. Okay, a single SERM drug can act either as an agonist or as an antagonist, but not both. False. Right? Because like we said, the same drug can bind to this receptor as an agonist, bind to another receptor as an antagonist. Okay. Okay. What is the most common side effect with the biphosphonates? Esophagitis, which is the reason we do all these horrible, instructions, basically torture the patient first thing in the morning. Do not eat for like an hour or two. Do not go anywhere. Just sit still, drink with full amount of water, and it's like so horrible. Drugs that act as antagonists of estrogen receptor in uterine tissue increase the risk of cancer. Really? False, because agonists would increase the risk of cancer. This is why estrogen therapy would cause, cancer, breast cancer and uterine cancer. And when combining salmon calcitonin with the human, what is the most correct? I'm comparing. So the salmon is more potent, it's true. It has a longer duration of action, it's more stable, it is true also. And then it's more likely to cause allergic reaction, of course, because it's different, human versus salmon. So all of the above. And this one here talks about, the conformational change. So too many sentences, but basically one of them is an induced fit for an antagonist, another one is an induced fit for an agonist. Okay, so A is agonist, B is antagonist. Okay, so would be answer A. But again, this part, the osteoporosis, is just for fun, okay, for your own education. And I just want to look at the applications really quick. Okay, we already, so one application was to explain the nasty butterfly that we had lots of mistakes at. Okay, and then which pharmacological class of estrogen receptor modulators can increase the risk of cancer? Which one, how could you increase the risk of cancer? By mainly agonist, right? But if you have a partial agonist, you could still increase the risk of cancer, okay? At the same time, if you already have cancer, use partial agonist, you could still treat cancer. Okay, you got it? The half cup empty, half cup full. Okay, because now you have too much estrogen. By giving a partial agonist estrogen, it's going to compete with the full agonist, and then now it's producing less. Okay. And then why do the classes selected above, which is agonist and partial, increase the risk of cancer? How do they increase the risk of cancer? They bind to nuclear receptor, intracellular nuclear receptor, and they enhance the DNA and protein synthesis division of that cell. Now, how can one SERM bind to a receptor as an agonist, but another receptor as an antagonist? It has to do with, you know, the receptor itself. So what the kind of receptor we have. So it binds in different binding mode to different subtypes of estrogen receptor. This is why we call them, you know, modulators. We don't use them. We don't call them agonists or antagonists. Okay. In fact, when they first discovered, I think they were calling them antagonists. But then later on, when they understood their mechanism of action, they switched the name and they refer to them as modulators. And then the last one we talked about already. So it's about the conformation change and the induced FET. This exercise is a comparison between all these estrogen modulators. What? So comparison between them and their effect on different parts of the body, and then what would be the ideal one. So our goal is to, of course, increase the bond density. We're talking about osteoporosis. So we're gonna hopefully find someone that increase bond density and, you know, decrease the activity on the breast and uterine, and also have a good lipid profile, and also does not cause deep vein thrombosis. We'll talk about, you know, DVT, deep vein thrombosis, next week. And this we talked about. Okay, so why do we have to follow special instructions? To prevent osteophagitis and to enhance the bioavailability, right? So taken on empty stomach to enhance bioavailability, but then standing still and, you know, waiting for like an hour, not eat anything, drink a lot of water, 6 to 8 ounces of water, to prevent the drug to be stuck in the esophagus and cause osteophagitis, okay? And of course, we already talked about this technique of, you know, giving both actonil and calcium together. They're not really taken at the same time. It's just they're given on a different day, okay? So you only have to follow these horrible instructions on one day of the week, and the rest of the days you can just take calcium regularly. Which one is poorly absorbed among all these forms of calcium? The carbonate, yep. Any questions about this so far? Any questions? Of course, you have no questions because you don't care about this part, do you? You're just being nice and nodding and like you pretend like you're listening, but like it's not in the exam. No, I know you care. I'm just messing with you. Okay, so this would actually conclude this part. And next we're gonna talk about review of the cat. Oh, you have a question? Sure. Absorption of the calcium. Yep, yeah. So vitamin D helps with the enhance the absorption of calcium from the intestine. I think it does that too. I'm not sure. Contradiction, right? Hmm. Does it? Does it increase the resorption? Hmm. Excretion. Hmm. Okay, so looks like the final outcome is increasing the calcium in the blood, right? But then I see your point is how does that help with the osteoporosis? Um, yeah. That's a good one. I'm not sure. Should yeah, your team. You can second one. Yeah, right. You're not allowed to attend my class anymore. Okay.